Good morning, everyone, and welcome to the Public Safety Solutions for Substance Use Disorder ECHO. My name is Maria Gutierrez, and I will be facilitating today's session. This ECHO is brought to you by the Center for Substance Use Training and Telementoring, also known as CSAT, and by Be Well Texas in collaboration with the UT Health San Antonio ECHO program. I'd like to start off with a few housekeeping reminders before we do begin. We do have live closed captioning available for today's session. If you would like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select Show Captions option. If you're having trouble accessing captions or having any other connection issues, please privately chat Echo IT Taylor as she is here to assist everyone. To help us with attendance, please enter your full name, affiliation, and email into the chat. We'd like to remind everyone to please stay muted unless you are speaking. However, keep in mind that we do encourage everyone to please turn on the video if possible, and also use the chat to raise any questions or pose any questions you might have throughout today's session. We also welcome you to use the little raise your hand feature. As a reminder, these sessions are being recorded and will be shared on our website. To ensure privacy, we do remind everyone that no personal health information is allowed at any point during today's session. This does include client, patient names, addresses, birthdays, or any other identifiable information. At the end of the session, the ECHO team will send out a post-session survey link. We kindly ask that you please complete this as it provides feedback on how to refine these sessions to better address your priorities for this specific ECHO program. We are approved for CEs for paramedics and any other public safety professionals with a behavioral health degree, such as social work or counseling credentials. Finally, ECHO is an all teach, all learn environment, and we really do encourage everyone to participate in the conversation today via, unmuting, raising your hand, or using the chat function as well. With that, we'll go ahead and get started with some team introductions. I'll go ahead and start with Dr. Brandon Del Pozo.
Hi, this is Dr. Brandon Del Pozo. Thanks for getting the accent right. I am an assistant professor of medicine and public health at Brown University. I came to this research, which is concentrated on criminal justice and the opioid crisis, through 23 years of policing, 19 in the NYPD, and 4 years as the chief of police of Burlington, Vermont. And it's always great to be here talking to folks in Texas.
Thank you, Dr. Del Pozo. We also have Cynthia Mendiola.
Good morning, everyone. Nice to be here. My name is Cynthia Mendiola. I am a retired federal probation officer. I did that for 27 years. I also have a license in chemical dependency counseling, and I presently work in child and family immigrant safety, but I'm also a trainer and coach in core correctional interventions. And happy to be here today.
Thank you, Cynthia. We also have Jeremiah Golka.
Hi, everybody. I'm Jeremiah Golka. I'm the executive director of the SHIELD training initiative. We provide occupational safety and health trainings for police, other first responders, criminal justice professionals in their work responding to the overdose crisis to provide techniques and strategies and knowledge that will improve their wellness, job satisfaction, effectiveness, and improve outcomes in their encounters with people who use drugs. Really looking forward to Dr. Gerber's presentation today.
Thank you, Jeremiah. And what a beautiful segue. I'll go ahead and have Dr. Garland Gerber also introduce herself.
Hi, everyone. I'm happy to be here. It's so great to see familiar faces and new faces. I'm Dr. Garland Gerber. I come from a clinical background. I have been a psychotherapist for over 15 years, working in substance use and mental health. I also taught a parenting best practices class for parents who are involved in CPS and other the criminal justice system. I am here to speak to weave in my personal experience with my clinical and research experience. I have a PhD in substance use on research on substance use, and I work with Jeremiah and everyone else at the lab working on SHIELD for criminal legal professionals.
Thank you so much, Dr. Gerber. And lastly, we'll have our case presenter also introduce themselves. Cody Ham.
Hi there, my name is Cody Ham. I'm the Senior Medical Specialist at Round Rock Fire Department's Crisis Response Unit. We're a co-response unit that responds to 911 calls with paramedics and social workers. connected into the 911 system, doing jail diversions and EMS diversions, getting people in behavioral health, substance use crises to the correct facility.
Thank you so much, Cody, for introducing yourself along with everyone else on the Hub team today. With that, I think we can go ahead and get started with some didactics. Dr. Gerber, you can take it away as soon as you get that share screen going.
Got it. Okay. So everyone see what they're supposed to be seeing? Okay, great. So I have a little script here because this topic is very close to my heart and I want to make sure that I cover all my bases. Thank you for being here today. Today's session is titled From Crisis to Connection, and we'll be focusing on how public safety professionals can effectively support parents struggling with substance use disorders. I'll be weaving in both clinical statistical information and my own lived experience to help frame these conversations in a way that is trauma-informed and actionable. Disclosures, I have no financial disclosures. However, I did share that I bring both personal and professional experience to this topic. And this background informs the passion and earnestness that I bring to this presentation. Before we dive in, let's review the learning objectives. So we'll identify the intersection of public safety and child welfare, review statistics on parental substance use, and most importantly, develop strategies that public safety professionals can use to support parents and children during field interactions. So I want to start with my own story. The picture on the left is the period of time and age that my son and I were separated. This was a monitored visit to the beach. You can see his excitement and anxiety, and I am smiling through tears and so much sadness for the apprehension of having to say goodbye in about an hour. I lost custody of my son for 18 months due to my substance use issues. And for those of you who aren't familiar with the Child Protective Services system, 18 months is the max that they give, at least in California, to gain rights as a parent back. Navigating CPS as a parent in active addiction was confusing and terrifying. Oftentimes, I felt vilified and misunderstood. How do you still keep using, even to risk losing your child, is what others, including my parents, asked me. And it's what I asked myself every day. Living in my car for about 6 months, I was removed from the home. I finally was able to find a treatment facility that would take me for 90 days while I worked so I could have stable housing and money to take 2 different buses to get to my random testing. Took 3 different buses to my parenting classes. The requirements set for parents often feel impossible, and the pain of not having your child or being called an unfit parent is soul-crushing. The picture on the right is May of this year at my son's college graduation. As a single mother in recovery, I've been able to put my son through college, achieve my master's degree, and a PhD in substance use research. I also spent a few years at a local clinic teaching parenting classes for others who are involved in CPS. Parents who struggle with substance use are not expendable and have great value to bring to the world, especially their children, if they can find environments that support their pathway to recovery. What a blessing it is that my child gets to learn from my journey. What made a difference was a collaborative wraparound team and the professionals in it who treated me like a human being and helped to make things feel less overwhelming. And that's why this work matters. So I'll move on. Substance use plays a role in about 60 to 80% of CPS involved cases, and over 80% of foster placements involve parental substance use. It's important to recognize that substance use alone does not constitute child abuse. These numbers should be understood in the context of broader systemic issues such as poverty, trauma, and limited access to behavioral health care. Additionally, many children involved in these cases are also experiencing their own mental health or behavioral challenges. Parents are often under-resourced, overwhelmed, or stigmatized and may not know how to respond, so they resort to substance use as a coping mechanism. This doesn't reflect a lack of care for their children, but a lack of support for the parent. Public safety is often the first system to engage families in crisis. In the context of public safety initiated CPS reports, substantiation refers to a formal determination by Child Protective Services that the reported allegations of abuse or neglect are supported by sufficient evidence. How you respond can de-escalate trauma or escalate it. Families remember these moments forever. Your words, tone, and approach can shape whether a parent reaches out for help or retreats deeper into fear and denial. A trauma-informed approach means recognizing that behavior is communication. This is vital, not just in your approach in the moment, but the way that reports are written. Many times parents are able to access services they would not have been able to navigate or obtain depending on what is written in the report. A parent who appears defensive may be afraid or ashamed or disoriented. It's about shifting from what's wrong with you to what has happened. When encountering a parent who may be using substances or is under stress, de-escalation begins with your tone and posture, speaking calmly, avoid sudden movements, and respect the parent's autonomy. Offer options rather than demands, like asking, "Can I offer you support or resources?" Acknowledging their fear without dismissing risk by saying something like, "It makes sense that you're scared. Let's talk about what's next." Avoid threats or shaming language, which often triggers survival responses. A defensive parent isn't necessarily being defiant. They may just be overwhelmed and in survival mode. Compassion is our most effective tool in these situations. The goal is for parents to be open to getting intervention without having to be removed from their children. Oftentimes, a report that goes unsubstantiated is an opportunity for early intervention. And as I say, as a clinician, and it's across the board, early intervention is the best intervention. Here are some signs of trauma, including hypervigilance, presenting as being shut down or any other type of emotional dysregulation. For parents, trauma often overlaps with substance use and fear of losing their children. So recognizing these signs helps you tailor your response to reduce harm and build trust. So let's talk about when children are present during public safety responses. When children witness confrontational or punitive interactions, it can be deeply scarring. They may blame themselves or be re-traumatized by the experience. I know that it took decades for my son to re-engage in any type of therapy or behavioral health services because of his experience with Child Protective Services and public safety. Speak gently, lower your posture to the child's eye level, reassure them with phrases like, "You're safe, we're here to help your parent." Use a calm tone when circumstances are tense. Your presence becomes a model of safety and trust. We are also setting the tone for how children will respond to and respect public safety officials in the future. When you're dealing with the parent, when children are present, be mindful of your language. Avoid words like neglect, abuse, or taking away in front of the child. Children absorb everything. Frame your actions as safety checks or support services, not punishment. Offer to step outside and talk while you assess the safety of the circumstances. The goal is to assess and support the situation without jumping to immediate separation. Make sure the child has someone safe nearby, whether that's a relative or a calm officer, and only involve CPS or escalate if there is a clear safety concern. Remember, and you'll hear me say this again over and over again, parental substance use does not automatically mean that a child is in danger. Context, compassion, and calm assessments matter most. So here's a summary slide of how to support families during field encounters. Modeling compassion, demonstrating care and respect for both the parent and the child. If possible, if at all possible, delay removal or call for additional support to allow social services time to intervene in a less traumatic way. The goal is always to preserve the parent-child bond when it is safe to do so. So here's some information on when to refer versus when to report. Not every situation requires a report to CPS. If the child is safe and the parent is coherent and willing to accept help, a warm referral to treatment or recovery support may be more effective. There's a lot of use of peer support specialists more recently. And if your area utilizes peer support specialists, this would be the ideal handoff. Use discretion and lean on your local protocols and support networks in cases like this. So I'm going to give some examples of models that work. I think I mentioned that what was helpful for us was a wraparound services program that came into the home. As I mentioned, my son was also struggling with some behavioral health related issues. He was diagnosed with ADHD while we engaged in wraparound services and was able to receive his own mental health and medication, which obviously places a lot of, removes a lot of strain on the parent, which supports recovery in many ways when both the parent and the child are getting the services that they need. So I will start with the START program. It's short for Sobriety Treatment and Recovery Teams. And as you can see, these are all collaborative. It combines CPS, treatment, law enforcement, and peer support. While it's not yet in Texas, this model has cut foster care entries by half in other states. At the end of this presentation, I will give some resources on how to bring START to Texas if you're interested in. It's a gold standard for multidisciplinary collaboration. Then closer to home, there's Williamson County's Family Recovery Court, and then also Travis County, which I'll show you on the next slide, Parenting in Recovery Program. I always say, this is just an addition to what I've been speaking about, that parents in recovery have two of the hardest jobs in the world. If you're a parent, you know that it is incredibly difficult on many days. And if you're in recovery, you also know that it is incredibly difficult on many days, especially when you are trying to find a pathway of recovery that works for you. These programs involve coordinated care teams that emphasize treatment over punishment. helping parents recover while maintaining or restoring custody. Here's the Travis County Family Drug Treatment Court Parenting and Recovery Program that I talked about. I also cannot stress enough how vital and important recovery housing programs that allow parents to live with their children can be. There are two that I'm offering suggestions here, the Magdalene House in Dallas and Clarity Child Guidance Center in San Antonio, which promotes emotional safety, family stability, and healing together, which is the best healing. I cannot begin to describe the pain and sorrow of waking up every morning and knowing that I could not see my child, wondering if he was thinking about me and missing me, and the shame that I felt. Then having to maintain my recovery felt even more impossible with the level of grief that I was experiencing. These recovery homes are not very common, but can save a parent and a child a lifetime of trauma healing. So here are some resources for Texas-based referrals, including the 211 system, the Oscar screening centers, and Padre parenting programs. Public safety professionals can connect families with these services during or after field calls. Here I have listed some national resources as well as how to bring the START program to Texas. And then I always like to, I know we'll have a case presentation, but I always like to put into practice what I've shared and the suggestions that I've given. So here we have a public safety officer responds to a welfare check at a motel where a mother is reported to be passed out in her room. Her 4-year-old child is found unsupervised playing in the hallway. The officer knocks, and eventually the mother answers, groggy and confused. She becomes emotional. Oh, empty alcohol containers are visible in the room. She becomes emotional and defensive, fearing her child will be taken away. The child begins to cry and cling to her. I do not claim that this is the easiest situation to be walking into. There's a lot of liability, there's a lot of concern, there's a lot of where do I start? But I think it's a perfect example of what is often seen, what a lot of public safety professionals and parents who are struggling with substance use experience. And so I guess I will stop here and see if anyone has any suggestions before I move into the trauma-informed approach. And if not, we can chat a bit after the presentation. Okay. So trauma-informed insight is always what we hope to use from the very beginning. Understanding the mother's perspective before we walk in and engage is vital. Oftentimes, and I can strongly confidently say this from my own experience, the mother is experiencing shame, fear of CPS involvement. Oftentimes, parents who are struggling with substance use, this is not the first time that they've engaged with public safety or CPS involvement. And perhaps some disorientation due to their substance use. Her response is likely rooted in trauma and survival. That's a very important thing to remember, in that most of the responses are not defiance. A lot of times it's fear for the apprehension of possibly being separated from their child. The child is witnessing the entire interaction. So next we move to looking at the child's perspective. So making sure that your tone, your body language, and your verbal language is critical to preserving this sense of emotional and physical safety. Small gestures of compassion from the officer or other public safety professionals. And that includes, as I've said before, a calm voice, non-threatening posture, clear communication. The goal initially is to de-escalate and for all parties involved to feel safe enough to be able to have a conversation and problem solve effectively. And this also, for the long term, reduces lasting trauma for both mother and child. So, effective responses, we went through. Your role is critical. Your first point of contact, a mirror of trust, and sometimes the only person a parent will talk to. You can offer context to social workers. One thing that I know was really helpful is when an officer walked me through every single thing that was going to be happening, what the plan was, who they were calling, what some of my options were. Letting a parent know that you are there not to make things harder, and that what your first goal is to make sure that everyone is feeling safe. You, again, explaining each step clearly, avoiding judgmental or shaming language, because I can guarantee you that a parent is doing that to themselves. Speaking calmly, maintaining non-threatening body language. Again, emphasizing support and using child-sensitive language. We're here to help your parent. You're safe. Everything is okay. As your role, making warm referrals, including the resources that I offered, to behavioral health teams, peer support specialists, and child welfare liaisons, is incredibly helpful and vital for a parental engagement. Offering context and observed strengths. I can see that you really care for your child. I can see that this is a difficult situation for you. Framing calls and visits as supportive check-ins, and when possible, at all possible, delay removal or escalation to allow Child Protective Services enough time to assess any sort of alternatives. Do you have somewhere safe you can go or leave your child for the next couple of days until you get your stuff together and find a local treatment facility? Opting for allowing a family member to care for the child while the parent engages in locating treatment or detox. Recognizing that compassionate tone and small gestures reduce trauma. Here are my references. I'm happy to speak more, answer any questions that you may have regarding any particularly difficult situations. And here is a picture of my son and I at my PhD graduation. You can't see it, but he is absolutely bawling and whispered in my ear, "You did this, Mom. You did this for us." Thank you for showing up to this important conversation. Your presence here means that you are doing this work differently. The way you show up matters. You can be the bridge between crisis and connection for families who need it most.
Thank you so much, Dr. Gerber. I truly appreciate and admire, your openness to sharing something so intimate and private to your life. And think that I can honestly say, as everybody else might say, is congratulations on the PhD. I think that is such an amazing an accomplishment for you. So thank you so much for that. I do see a comment, a few. So thank yous. Thank you for sharing. Great job, mom in person. Thank you for being so vulnerable. Anybody have any questions for Dr. Gerber today? Or any comments? Lindsay, I do see your hand is raised.
It's not a question, it's more of a comment that it really I loved your presentation. It means a lot to me. I had a very bad run-in with CPS when I checked myself into a mental hospital, right? And like they ended up, even though I had care for my son and he was with his dad, I knew exactly where he was. We set it up ahead of time. They sent straight to CPS and they took away my kid while I was in the mental hospital, right? Which
Oh, yeah.
I couldn't do anything about because I didn't have the resources to fight it, and so like that really stopped me from ever trying to get help again when I had a child, it
Exactly.
good. And that's
Exactly.
and my child
Exactly.
was perfectly safe, but I was not after that. So
Exactly. Yeah. And I think, I made the same statements over and over in the presentation because it is, in fact, so very true in that when you are engaging with a parent and children, you are really setting the stage for the comfort and that a parent and child feel in presenting their problem, number one, and being willing to access and ask for help. And that's why, finding the strengths in the situation, letting the parent know that you see that they care for their child and that, it seems to be a very overwhelming situation and that you'd love nothing more but to find some strategies to help them support or help support finding a pathway of recovery or help that feels good for them and continues the parent-child bond. Because as you said, when that situation comes where you're separated from your child, you feel helpless and you feel, I know a lot of parents that I have worked with in the past who have lost permanent custody of their children, and oftentimes it's all downhill from there. Because, whether you like it or not, your children bring you a lot of purpose. They bring you a lot of stress, but they bring you a lot of purpose. And once you are removed and you are unfit, and you think about the language that is used in the system, unfit as a parent, that really does a lot of internal damage to a parent to hear that. And so again, the tone, the language, the compassion that you can access, building the parents' strengths while you're engaging with them, it lasts a lifetime. Thank you for sharing that, Lindsay.
the other part of it is at the very least being very upfront. So I signed away my rights as a parent because I didn't know that was what
Yes,
was happening. They told
yes,
me that I had to do this or they would take my child away through the court. Well, that was
yes,
not the case.
yes,
So especially
yes,
being upfront and transparent is always
yeah.
helpful.
Yeah, yeah, yeah. And I think again, I'm so pleased and so grateful that public safety professionals are care about the topic, but there's a whole system that needs to be educated on how to best interact with parents and support family reunification as opposed to family separation.
I do see a few comments in the chat, one from Cindy. I appreciate your vulnerability, ladies. I wish when I was in comorbidity behaviors that someone would have intervened for me. Not great at the moment, but look how far you both have come. And then I do see another message from Cynthia. Thank you for sharing your story, referencing the profession and better ways to provide service that will reduce trauma. Any other questions or comments for Dr. Gerber today? Okay. Well, thank you everyone for, providing Dr. Gerber some amazing feedback for today's presentation. I'd like to move on over to announcements with everyone for today's session. Taylor, when you have a chance, if you can please pull up the announcement slides, please. To claim any CEU credits, you must complete the post-session survey in the chat or by email sent after the session. Complete the post-session survey and select yes on the question, are you applying for CEU credits for today's ECHO session? Your certificate of completion will be sent to you 2 to 3 weeks after the session today. If you have any questions, please email bwelltexas@utesca.edu. Next slide. The Center for Substance Use Training and Telementoring offers technical assistance for various substance use disorder needs and topics through our network of subject matter experts. To request technical assistance, please complete an online request form through the link in the chat, and we will be pleased to help you out. Next slide. The Texas Substance Use Symposium is back on March 2nd and 3rd, 2026 in San Antonio, Texas, and we're thrilled to reunite our statewide community once again. We're also excited to introduce a new Texas Regional Summit this fall in El Paso. If you are in the area, stay tuned for more details are coming soon. For any updates, please visit texasus.org. Next slide. Join us for next Texas session with Speaker John Kamala on a discussion on how to evaluate and navigate through today's policy and funding landscape. Register today by scanning the QR code or visiting the link in the chat. Don't forget to join our next month's session for the Public Safety Solutions Echo on Thursday, August 14th at 11 a.m. Our hearts are with the Kerr County and surrounding communities affected by the recent flooding. If you or someone you know has been impacted or would like to help, the following resources are available to support local families during recovery. You can scan the QR code or use the link in the chat. Thank you for that, Taylor. As you all can see, Taylor has been doing an amazing job of posting links in the chat. With that, I'll move on over to our case presentation for today. Cody, you may take it away as soon as you see that share being screened.
All righty, sounds great. Thank you. All righty. All right, so the case that we had was a couple months ago. We had a 40-year-old male, 911. He was activating 911 regularly, and our police department was out with him. They requested that we come and assess him, so our social worker and myself made the scene. When we got there, he had reported that he struggles with schizophrenia and stimulant use disorder. He's been calling 911 because he's feeling paranoia about people following him. He receives a long-acting injectable paliperidone and also takes risperidol. Unfortunately, due to some conflicts with his roommates, he was asked to leave his home where his risperidol was. And because of that, he had been several days without it and using stimulants for several days. We were able to assess him, and we found him to be appropriate for an oral olanzapine antipsychotic protocol that our team has. We were able to medically assess him, give him some oral rehydration, give him this oral antipsychotic olanzapine, get him down to the Austin Sobering Center, where he stayed for about 24 hours. We got him an Uber ride that next day to his job, with the plan being that in the morning he would call us and we would get him from his job to Rock Springs for a detox for under the CASA grant. From there, he was able to receive longer care, receive his long-acting injectable as it was up, and receive detox treatment. He then moved down to a respite step-down unit before moving to longer-term rehab where he still is. We also provided him naloxone rescue kits and a safety plan with him. So I'll go through the different lines on here now. The strategies that we employed is we used our olanzapine protocol and Uber Health to get him to a sobering center. We got him, if we could scroll over just a little bit, detox services, and we got his long-acting injectable up and running again. We provided him some education around the local drug supply. We've been seeing a lot of overdoses, opioid overdoses due to cross-contamination of stimulants. We were able to discuss the form. He'd been smoking it. He had not been injecting. And so we were able to, provide him education around that. We were able to collaborate with him, most importantly, and that's the power of our olanzapine protocol, being able to collaborate with the patient, get them all set up for the services they need, and kind of turn down the level of psychosis they have before it turns into something where they have to be, taken against their will, put on a notice of emergency detention, and get them into long-acting services. Because of this, we were able to get a really thorough collaborative safety plan with him that met all of his needs. He was afraid of missing work. He was afraid of getting in trouble. And he's also kind of concerned about his long-acting injectable. He's very, very engaged in his treatment and was calling his case managers and letting them know, but he knew that his psychosis was heading to a point where pretty soon he wasn't going to be effective at that. He's also afraid of losing his job. So because of this, we were able to kind of find this really specific intervention that fit all of his needs and really built some strong rapport so he could lean into us when we needed it. A nice combination of medical treatment and getting him into long-term wraparound services. Yeah, we could scroll over just a little bit. One of the things that we really wanted to do was keep him from not having to have a lot of run-ins with the police department, right? He was very nervous about activating police, and police understood that this probably wasn't the best resource for him, as it was a symptom of his paranoia. Even the patient himself recognized that. He said, I just feel like someone's coming to get me, and I feel like I need someone to protect me. And luckily, with our really strong relationship with our local police department, we were able to get that strong referral in on scene and start managing then and there, clear PD, and just have us there managing this, working through. We were able to get this really strong rapport and administer that antipsychotic on scene and kind of tie all the loops. I have to say that we used the COSSIP grant for this gentleman. So we were able to make a phone call to the local mental health authority, and through our OSAR providers there, we were able to get him a bed secured within like 20 minutes, which is fantastic. And our team has been using those beds and having a lot of success because of these. We're also concerned about the stigma of the substance use and the behavioral health condition. We know that this isn't an easy thing to ask for help for, and we had to be very gentle on how we approach this and find really pragmatic ways to get him to buy into this treatment plan. Luckily, he wasn't suffering from too much anosognosia and was willing to take that long-acting injectable. If we could scroll down just a little bit. Lastly, what I would have liked to do is discuss alternatives for his return to work. That was a point of anxiety for him that he was really stuck on. I was concerned because his job was in carpentry. It involved machinery, and we were providing him an antipsychotic that does have some, not a lot, but a degree of sedative properties. What we were concerned about, was maybe him coming into work and there being an accident. Luckily, he had a great relationship with his employer, who was able to say, "Hey, we're going to keep you kind of on light duty today," and he was able to just kind of reach out to us and call from his work phone, saying that he was ready to go to the detox bed. So it was this nice little plan that we had tied in, and he was able to make his job, show that we saw that we understood that was a very important piece of his life and his treatment, and that really was some trust in the bucket that we were able to lean on later. I think success for this one is his continued access to care. He was able to maintain his long-acting injectable, get all the treatment he needed without there being any kind of negative health outcomes, any further law enforcement involvement. He's able to kind of sleep off and let the antipsychotic take its course and let it start working, kind of clear him up a little bit so he could engage in the next steps of treatment a little bit more willingly. He was making regular calls to us once he was in the facility, the behavioral health facility. And because of that, we were able to tie in with the local mental health authority to make sure that he did receive that long-acting injectable before moving to longer-term rehab. I would love to, for us, what I think this looks like, and one of the things is we have a great care. This is a great toolbox for our dual diagnosis patients that are uninsured and underinsured. One thing I'm interested in is figuring out a method and a way for us to start carrying some of these commonly prescribed long-acting injectables, working with local mental health authorities to make sure that our patients aren't missing these. We know that anosognosia is a major cause of patients not engaging in treatment, and we really want to find a way to start that, have that going. So that would be our next step, I think, in tightening things up. Can we scroll down a little bit? Could we scroll down a little bit more? Great. So the referrals that we were able to use was the COSSIP grant, Comprehensive Opioid Stimulant. I'm missing it here. There it is. Okay. Use the COSSIP grant, the Comprehensive Opioid Stimulant and Substance Use Program. It works so great. We have such a great relationship with our partners at Bluebonnet Trails for this. The OSAR team over there is fantastic. With almost every single time that we've used this grant, They have 12 beds currently held at a local behavioral health facility for dual diagnosis. It has been under 20 minutes in which I've had a bed secured, funding letter sent, and I'm able to transport. So I can be on scene. I can do my assessments. I can have my behavioral health specialist do our assessment. We can get all of our medical interventions, get a medical refusal down, and then provide a courtesy transport to this facility. And it's a very, very effective kind of piece there. I think the Sobering Center in Austin has also been super collaborative and a great partner with us. And lastly, this kind of underused tool that our Uber, or not underused, but we don't give it enough credit, is our Uber Health. It works so great. Uber Health is such a nice tool for us to start getting providers. I do want to let you guys know that if you ever use it, these folks are not necessarily receiving any additional training. They are actually just usually your cut and dry normal Uber driver. So it's just someone, working the gig economy. So keep that in mind that like if you do receive some, odd looks or some information when you're bringing the patient to them, understand that like this person wasn't expecting this potentially. And so maybe giving them a little bit of like, don't have to break HIPAA or anything like that. But like, hey, like we're just getting this patient to where they need to be, because the last thing that our patients need when they're experiencing all this is an Uber driver to drive up, take one look, and drive off. We've had that happen before. So if we start preparing for that, that's one thing that you can be a little bit more successful in. My questions, we can go scroll all the way to the top. How do y'all manage client relationships with their employers during crisis? How do you all work through that? Like, how do you manage the HR piece and HIPAA and also advocating for your client? What do y'all do? Another question I had is, how are you navigating it says long active, but long acting injectables for patients if it's needed? And have you seen any correlations between increased stimulant use and decreased efficacy of your long acting injectables? I am seeing some of that, but I don't know if it is because of other stressors, the lack of sleep or anything like that, or if there's some sort of metabolism going on that we're not seeing. So I just want to throw those out there. That would be a good point for discussion. Thanks, all.
Thank you so much, Cody, for that very great case presentation today. At this time, I'd like to open up the floor for a case discussion. Are there any questions or comments from our learning network for Cody today?
I've got a question. Thanks for the presentation, Cody. I guess I think at least one or maybe more people in the chat were kind of essentially saying like, cool case. This seems like less of a how do we do it better than more like a bit of a model of doing things well. So how, in terms of providing your phone numbers or to the patient for follow-up, like is that a common thing that you all do? Can you kind of talk a little bit more about that and how that works in the workflow?
Yeah, absolutely. So kind of the timelines of our calls is we get activated usually through 911. We also have a call-in line. After that, when we start making that contact, we'll give them our personal business cards, and each of our providers carries a city phone that we can maintain contact with. Maintaining the contact with the cell phone is one of our greatest tools because we do also have brief case management services. So we can start getting them tied into those. And it's really nice. Like I have to say, in terms of rapport and support, having the person that was there on your overdose or the person that was bagging you or giving you Narcan, be able to kind of walk you through the next steps has been such a powerful tool. So keeping that direct phone line, of course, we let them know, hey, at 6 p.m., we're off. Call our general line if you need something, leave a message, and then we'll follow up in the morning. And that's kind of been the flow so far.
And did you have was there pushback when you all started doing that, or was it kind of like an organic thing you started trying out and finding effectiveness to it?
Yeah, I think it's been an effective tool. We were a lot of our members have been doing this work and this crisis response work and this method for probably like 15 to 20 years. And that cell phone, having that direct line kind of pulls them out of the 911 dispatch system for those high utilizers and provides a direct to provider link that avoids a lot of extra 911 calls. Because of that, we've really been able to make the case for keeping units in service, keeping providers in service.
Lindsay, I see that your hand is raised.
How do y'all handle if somebody refuses to go?
Yeah, that's a great plan. I mean, if at the end of the day, if we're going to do our assessments, right? If our behavioral health specialist does not rule or decide that they are a threat to themselves or others, or make any grounds for like a notice of emergency detainment, and I've also ruled that there's no medical emergency here, or they're unable to consent medically. If they're both able to do those and they ask for us to leave and they don't want us there, we're going to try our best to safety plan, right? But we're going to try to find what is going to be the best, least harmful collaborative approach, right? So like if this gentleman had really been like, no, I'm not going anywhere today. I don't want to take any medication. I don't want to do anything. The least we would do is, all right, well, can we at least get you some Narcan? Can you hold on to these kids for us? Here's our number. If anything changes, please call us. And then we can also like let PD know, hey, we're working with this individual. So let's try not to hit them with a camping ban. Let's try not to, get them, place them under arrest if we can avoid it, and we can start building a relationship with this person until we can get to that point. Does that make sense?
And how do you handle calls from like facilities? If there's somebody, let's say in a memory care unit who is actively a threat to themselves or others.
Mm-hmm. Those are really interesting and really fun. And I mean, not for the patient, obviously, but what I mean by that is we get to use part of our muscles maybe that we don't usually use. And when we go into those calls, we're utilizing the case managers at the facilities. We're utilizing first responders. Usually that is a medical need. So we're going to rule out the medical need. And that's the power of our dual assessment model. I'm going to see like, hey, is this agitation because of a stroke? Is this because of a new onset infection? Is there something else going on here? And if not, do we need to send them to a higher level of care? We can help coordinate between the facility, APS, and whatever that receiving facility will be. And in the meantime, if they do need a medical intervention or anything like that, we can also coordinate EMS saying, hey, maybe we don't need to give this person ketamine or, a Haldol or something like that. Maybe we can give them a lower dose, something like that, or get them, kind of to collaborate with us to the best of their ability.
Last question, I promise. Can we get can you put your number in chat or message it to me or
Yeah,
something?
absolutely. I'll make sure that I get all of our stuff in there.
Thank you.
Andrea, I see your hand is raised.
Yes, I had a question. I think that you mentioned that at some point his prescription medication was locked up or somewhere unavailable in that place where he didn't have any access to. What do you do in that case? Is it possible for you guys to contact someone else who can momentarily or temporarily prescribe another similar one for the time being, or how do you handle that?
It's very unique to the time and the situation. That is why we also carry that low dose olanzapine, because we do find that a lot of people have at least maybe a PRN analog to that medication, low dose, second generation atypical antipsychotic. For those other medications, we have a couple options. We do have a telehealth service that we will pay for an appointment. Our behavioral health specialists will do that part. If we have someone that is in withdrawals, we can also manage that and get them on buprenorphine or Suboxone with the same app. We do have to contact our medical director. We are working on expanding because I'm under medical direction under Dr. Taylor Radcliffe. He's the medical director for Williamson County EMS, and we are a first responder organization underneath him. So I basically would reach out to him if I feel like, hey, can we just get this medication refilled real quick? I can try that. Oftentimes it's us just calling pharmacies and seeing if it's already filled, and then we go fill it and try to pay for it, and we can do all of that. So what's nice about our teams, we have the flexibility that I can stay on scene, keep you medically stabilized, keep you de-escalated, talk shop, maybe give you some of our antipsychotic if it's indicated, while we go and pick up your actual dose. And right there, boom, we just tied the knot of continuum of care. So it's really case dependent. We have some tools to help us buy us some time and to work through that, if that makes sense.
Any other comments or questions in regards to Cody's session questions for today from our hub team?
I have a more general question, or just in your experience, like one of the things that concerns people about stimulant use and police response and high utilization in 911 is that stimulant users can be more unpredictable or dangerous, and even if you kind of stabilize them or help them, they're always more susceptible to like acting out, and so you need the police to constantly respond or keep tabs on them. So I guess the general question is like, what's that like in your experience? I mean, is it? I know I'm asking for anecdotes, but is there this need for police to respond, to co-respond to stimulant incidents because of potential for violence, or is that overstated? Did you follow my general question? I think
Yeah,
it's something on
absolutely.
top of mind.
Absolutely. I think it's kind of a similar issue that we see, right, with just your regular like overdose response, right? In our area, we get an automatic PD response, right, to those kinds of calls, and not necessarily. Oftentimes, it's just a medical intervention that's needed. And what we're finding is that when we actually minimize the number of responders with someone with stimulant use, you're also minimizing the amount of stimulus that you're providing, right? So a lot of those folks, their nervous system, you see a bunch of police show up, and that's what you've seen before. Your trauma response goes, all right, it's party time, because that's what I've seen so many times. What we Where we are successful is when we have a limited number of responders and we have a good relationship. Most of these people we're seeing time and time again, and we're keeping in mind the dual diagnosis nature of a lot of people that struggle with stimulant use disorder, right? So we're able to avoid a lot of PD responses as long as they are not in that super, like that hypermetabolic, the hyperactive delirium state, right? Where you have that perfect storm between your stimulant use disorder and your psychosis, and you're like truly cannot be de-escalated, right? That is a highly acute medical intervention that like might need police assistance in terms of like securing the patient to administer a sedative. That's the only time that I feel like it's really, really needed. Beyond that, we've been very successful with de-escalation and keeping these patients, really, really with us, even throughout their unpredictability. I think a good de-escalation providers that are great at that space, at that felt calm, at reducing stimulus. The more you do that, the more successful that you're going to be. And often our folks, our police department knows we're calling crew the second we get onto the call with someone with stimulant use disorder, because they know how to speak it better than we do. And if there's nothing else going on, we're just going to go through.
So I hear you saying that like a small group of like if the police know the first responders, know their colleagues in EMS, the paramedics, and are willing to let them take the lead, then you can have like and respond in like not a huge crowd but smaller numbers. You can get a good, safe response.
Absolutely,
Yeah.
absolutely. And that takes a lot of cross training, right? And a lot of, so like I just finished teaching all of our fire responders, hey, when I get on this scene, how do I minimize and do like restraint reduction, right? And de-escalation that like is trained in behavioral health hospitals all over behavioral health hospitals all across the world. Pre-hospital medicine and first responders don't get as much of that, right? And so to start incorporating some of that into our practice has been super, super useful. Hey, fire guys, when you get on scene, if this person, let's determine the difference between being agitated and being aggressive, right? And being able to kind of determine that and understand. We use something called the Richmond Agitation and Sedation Score, right? And using those scores and then our understanding of the patients, we're able to minimize that response. Hey, let's go in with 3 at a time. If they're allowing me to take vitals, there's a good chance that we're going to be able to get through this call without going hands on, right? We also find that if PD goes hands on and it's hands on right away, then that's where we are. Let's try to minimize. Let's move from there. Our police department also utilizes the RAP, and which is a device, a restraint device to keep folks sitting upright, maintaining their airway. And we provide a lot of pearls to our providers. Okay, if that does happen, if you do need them, call PD code 3. You're going to back out if it's not safe for you, right? You're going to let PD do their thing. They get them in a wrap. You still have access to do all your assessments. You can still transport, and here's your expectations. So that really thorough relationship of like, hey, this is a medical emergency that we need PD's help with, right? As opposed to maybe like this is someone that just needs some talking down and some de-escalation.
Dr. Gerber, I see you put a comment in the chat. Did you want to go ahead and address that out loud?
Oh yeah, so I'm my specialization in my PhD is not pharmacokinetics or pharmacodynamics, but I do know that excessive stimulant use, like methamphetamine use, can cause dopamine dysregulation, and that can actually affect long-acting injectables.
And see, that's what I was wondering. I was wondering if it was the dopamine piece or if it was this increased flow of of everything causing a hyper, because we know, like I said, that hyperactive delirium patient is in
Yes.
a hyper
Yeah.
metabolic state. Does that mean we're
Yes.
burning off that long acting injectable? You know what I mean?
Yep.
So that's
Yeah.
great. Thank you.
Yeah, it's not I from what I remember in my classes, it's not necessarily a metabolism thing, but a dynamic thing with the dopamine
Makes
system.
perfect sense. Thank you.
I know we are at the top of the hour, everyone. If I could have Jeremiah give us a case summary for today.
Sure. We're just trying to be real quick. This is just a great presentation today. There's two presentations today, like really interesting stuff. And I think if you don't mind me going kind of off what I'm asked to do, and instead of point out some kind of really interesting connections here is the de-escalation and pre-escalation themes that are being brought up so strongly. And they come up so often through these echo programs, and basically how can folks who are the responders, whether they're EMS, paramedics, law enforcement, others, can come into a situation, and as we increasingly recognize, they can make them worse, they can make them better, they can maximize effectiveness. But so much of that comes down to the experience, knowledge, and kind of emotional regulation of the responder to be able to slow something down and recognize what's going to work and what's not going to work, or what can make things worse. Understanding these survival responses can make people like more obstreperous and difficult to handle, and so trying to manage handling that. And then with Dr. Gerber's presentation, one of the kind of key things there is that recognizing that child separation is like a nuclear option, and you do that and making things worse for everybody, right? You're making recovery so much more difficult for a parent. There are these likelihood of the foster care to prison pipeline issues for children, the lack of interest of all parties in using supportive services is like so challenging. And on the flip side, Cody and your colleagues, when you're handing your phone numbers and saying like, no, we're really actually going to be here in a way that some other programs only seem to work well if they have like peer coaches or peer supports in there who can then help people navigate and call, follow up. And we actually are here. We do care. This isn't just a one-off situation. Um, that can then that kind of caring uh, may then help increase the likelihood of using services. So really cool. So thanks y'all for presenting. Thanks everyone for being here today.
Yes, thank you everyone for staying with us 3 minutes past the hour. As a reminder, to seek any continuing education credits, please complete the post-session survey that is in the chat. Thank you again for everyone for joining us, and we'll see you all at the next session on August 14th. Thank you.